Thanks, Anita. It's great to be here. I'm here to put a few more cats among pigeons. And it's, of course, always good to be in Liverpool, which is, as we know, a city that takes itself very seriously, and rightly so. As I was visiting Broad Green Hospital this morning and talking to some of the patients and volunteers there and our NHS England office, I was presented on the assumption that it's the one book people assumed I would always have wanted but have not yet received, with the history of every Everton and Liverpool football match that has ever been played, with a breakdown of who scored when, at what point during, so I can just, a random 6th of February 1915, Everton 1, Liverpool 3. Good to know. Or 27th of April 1977, Liverpool 3, Everton 0. Attendance 52,000. So anyway, for anybody who actually has a real passion for this stuff, see me afterwards. But in the meantime, we do meet here at a defining time for the National Health Service, a time when standards of care for the vast majority of our patients have never been higher, when the nation, as a result, owes you and all of the staff of the health service a huge debt of gratitude. But it's also a time, as we know, of the most intense public focus ever on the quality and safety and dignity of our care, coinciding with the most sustained budget crunch that the health service has seen since the Second World War, and we're now, of course, in the 5th year of that very long funding squeeze. And all of that's playing out against the backdrop of multiple, fundamental, long-range challenges to our health system, a growing population, another 3 million people living in this country by the end of the decade, an aging population with more pensioners than children now, growing challenge of obesity, dementia, multi-morbidity, and of course, in many ways a good thing, more expansive and more expensive new treatments. So these are challenges that I think are now quite well understood, and I think the NHS Confederation has done a very nice job in laying them out in the 2015 challenge that Rob was talking about a moment ago. And in fact, a combination of governments and think tanks and patient organisations and various others have, I think, put great effort into classifying, describing and quantifying the challenges that we face. But as I've been out and about around the country over my first few months in this job, talking to patients and carers and staff and managers, my sense now is this. I think we're done with analysing the challenges. I think people actually want to get on with developing the solutions. Let me just say, by the way, that I don't think that thinking about tomorrow means that we can or should take our eyes off today. This year, we are going to have to continue, you are going to have to continue to move heaven and earth to sustain the high performance that our patients' lives are depending on. Speedy access to emergency services, short waits for planned services, high-quality cancer care, modern mental health, safe staffing, compassionate care, a culture of openness improvement, and much more. So thank you for everything you've done. Please keep on doing it. We have come so far on most of those patient-facing goals that to drop the ball at this stage would be a terrible loss. Now, I know there are enormous pressures, and I get the funding questions, but I also think that the NHS is up for change. Necessity is truly the mother of invention. And so I think the question for us all here in Liverpool is, how do we mobilise for this next stage of the NHS journey, being respectful of our history, but not a hostage to it? A single national roadmap at this stage would, I think, be to miss the point, because it's actually going to be the energy and the commitment of our staff, your staff, of our patients, our partners, that is going to solve what we need to solve for. So we need, I think, direction without dictation and different answers for different communities. In that context, I think it's hugely encouraging that when you look at the staff survey, 3/4 of staff say that they can make suggestions about how care can be improved. But I have to tell you, a rather lower proportion think that those ideas are listened to and acted upon. And I think our recent history tells us that the NHS does best when it listens hardest. That's why having an open culture, a culture that pays attention to staff, where there are issues, nips them in the bud rather than allowing them to fester, that sort of culture is the culture that we all want to see. So, on the subject of cats and pigeons, today I want to offer 3 thoughts on big-ticket items that I think we've got to solve for over the next 5 years and beyond, and perhaps reframe some of the recent debates that we've been having as a country on health. And I'm not going to repeat the thoughts that I shared with CCG clinical commissioners at their annual conference, or some remarks I made at the King's Fund at their annual leadership conference about the kind of inclusive leadership that the NHS now needs, which I think fits with a lot of what Stuart was just saying. Instead, what I'm going to do is concentrate on 3 aspects of how we, as NHS leaders, can together take the next steps to improve care and future-proof the NHS. Here are the 3 I'm going to just concentrate on today. First, improving the sophistication of our commissioning. A new focus on outcomes for patients and value for taxpayers. The demand side, if you like. Second, accelerating the redesign of care delivery with far greater local flexibility to meet the health and social care needs of the people we serve. And third, actively exploiting and embracing the fundamental transformations that I believe are about to sweep modern Western medicine and shift the frontier of what is possible. So let me just focus on those 3, starting with commissioning. Well, what is it we're trying to achieve with commissioning? I mean, in some ways, commissioning is incredibly poorly understood and little used tool for improvement. And I think what we're trying to do is this. NHS commissioners exist to unleash more health and care bangs for the buck. Our job is to drive greater value than would have been the case just by perpetuating the status quo. And talking to patients and the public around the country, I think there's actually quite wide agreement about what people are looking for from the NHS. It's not surprising, it's not unreasonable, but that doesn't mean it's either easy or inevitable. Our neighbours, our relatives, our colleagues, they want reassurance that care will be readily available when it's needed, that the care will be safe, that treatments will work, that services, the left hand and the right hand will know what they're doing, that our staff take patients' preferences and dignity seriously, care that's fair and non-discriminatory and non-wasteful, which I've kind of tried to summarise with the thought that the onus is on all of us to think like a patient and act like a taxpayer. Well, at a national level, those broad democratic aspirations are fleshed out through the mandate, which the elected government of the day sets for NHS England now, and through us for you, the NHS. And for anyone who wants to know what NHS commissioners are here to do, these are the 5 overarching domains that we are tasked with improving. And that's how commissioners' impact will ultimately be judged. The simple clarity of these 5 domains, which require some incredibly complex causal chains, should constantly prompt all of us to question why we're doing something in a particular way. And that's where commissioning comes in. As a nation, we've just taken the unique step anywhere in the world of entrusting frontline clinicians with 2/3 of our health service funding, £67 billion. And many CCGs, frankly, are now genuinely harnessing clinical insight and energy to drive change in the local communities in a way that had not been achievable before now. Again, I want to give you a practical example of what that might mean. So on Sunday evening, as I was thinking a bit more about this speech, sitting at my kitchen table, I went on the web and I thought, I'm going to pull the data for Liverpool CCG. I don't know, is there anybody in here from Liverpool CCG? Yes, okay, well, in the event that this data is wrong, please feel free to keep quiet. But all I would say is it's just kind of on your website. So the question I was asking myself was, if I was Liverpool CCG and I was looking at what needs to happen to improve health in Liverpool and to drive the healthcare system here, what would be the kind of goals that I would set myself? And actually I have to say that as I've looked a little further at what Liverpool will be doing, I've been incredibly impressed. The Liverpool Health Strategy, the commission that the Mayor of Liverpool has pulled together and helped lead, I think sets out a fantastic blueprint for the kinds of changes that are needed and that the CCG gets great credit for. But anyway, here is the chart that I could find on some parts of what Liverpool CCG is trying to do, and effectively what it shows is that if, as commissioners and as a health system and as a community here in Liverpool, we can reduce premature deaths to levels similar to other comparable CCGs, I'm not talking about Cheshire or Surrey, I'm talking about comparable CCGs, we can, here in Liverpool, save 409 lives a year in these specific disease areas alone. So that's 400 families no longer losing a loved one in their prime. And that's why we're here. So that, of course, is going to take tackling the wider determinants of health, but we're also now beginning to move through the commissioning system to link providers' funding with the sorts of improvements that we want to see. How we do that's obviously going to vary by the type of service, different pace, different places. And together with Monitor, we're going to be testing new types of reimbursement models, some elective conditions, year of care for long-term conditions, alternative funding arrangements for emergency care, and so on. But I also want us to get serious about looking at how we commission for care pathways so that we end what strikes me, coming back to it fresh, as the nonsense of commissioning bariatric surgery independent of upstream commissioning for obesity prevention, for example, or commissioning £1 billion worth of medium and low secure psychiatric services separate from a conversation about what needs to happen to mental health services in each local community. We also, if we're going to get smart about commissioning, need to take a better look at incentives. And NHS England, my organisation, is currently expecting to spend about £2.7 billion a year on various performance incentives for community and acute providers, for GMS GPs, for CCGs, and I tell you now, we're going to be taking a very hard-nosed look at what we're actually getting for that money and whether we can do better. More broadly, across all NHS-funded services, I'm going to be pushing for a steadily increasing proportion of payments that are tied to performance, quality, and outcomes, and different approaches to sharing utilisation risk for particular services along a spectrum. So we're not just paying for activity, we may also be sharing population-based budgets where that makes sense. So I don't have a chart for it, but if you thought about it as a chart, you would think about a y-axis and x-axis. One would be pay for doing things versus a proportion of the pay tied to quality. The x-axis would be pay for doing things versus pay for looking after defined populations. Various points along those two spectrums, that's where we're gradually going to be moving different parts of our commissioning system. And we're also going to be raising the sophistication of commissioning by getting more timely, coherent, and actionable information in the hands of clinical decision makers and frontline commissioners, taking a pragmatic look at the evolving division of labour that needs to go on between CCGs and CSUs and NHS England, really driving our world-class, and genuinely it is actually a world-class transparency agenda in this country in partnership with CQC. New ways of giving individual patients more clarity in the commissioning process, working with local authorities on better ways of effective targeting care, including the Better Care Fund, getting the third sector involved in commissioning decisions, perhaps around learning disabilities and cancer and mental health problems for starters, thinking about new places to draw where the commissioner-provider boundary should sit, as I'm about to go on and explain to you. Partnership with Public Health England, beginning to think not just about the flow of healthcare transactions, but the stock of population health risk, giving virtual population-based budgets that reblend primary care and hospital and community services and specialised commissioning so we can have a conversation about place as a basis for fairer outcomes and allocations, and defining more rigorously, frankly, the data that will be used to reveal whether we as commissioners ourselves are doing a good job. So all of this stuff are going to be, I think, important enablers of what we need to do in order to improve sophistication of the commissioning system, but they're all means to an end. And that brings me very firmly to the second of the three main things that I wanted to mention to you, which is how we're going to redesign our care models, how we get much greater local flexibility to match the different needs of different parts of the country. And I would just at this point say, as an aside, rather than constantly debating the reorganisation of NHS management tiers, it would be good if we could actually now concentrate on the much more profound questions about how care is actually being delivered. Because for anybody in this room who's a historian of the NHS, you will know that there's almost no administrative permutation that hasn't at some time or another been contemplated for the NHS. And I'm going to share with you today secret cabinet papers discussing a future reorganisation of the National Health Service. And what these are genuine minutes from the cabinet discussion. They show that proposals for an integrated service have been generally welcomed. This is what the cabinet discussion said. It went on to a discussion about how many areas, how many local units, middle tiers, regions, and so on to have. But in the context of a relationship with local government, said rule out transfer of full financial responsibility because of the accountability of the Secretary of Parliament and opposition to the medical profession. But hey, we need managers who've got both medical and managerial experience. So I also tell you that the same cabinet meeting that discussed this, it's there in the minutes, decided that health services for the under fives should transfer to local government. They debated the London Underground. They were concerned about top salaries in the public sector and flooding of the River Thames. That cabinet meeting took place in January 1970, and Harold Wilson was the Prime Minister, Richard Crossman was Secretary of State. So, while historical debates on NHS management structures do have a somewhat repetitive quality about them, the way that healthcare itself has been evolving continues to be quite amazing. And like every healthcare system in the Western world, medical advances and the search for the efficiency mean that the NHS has been developing new services and closed unneeded hospital beds since the day it was created. Antibiotics for TB, antipsychotics for mental health problems, short-acting anesthetics, minimally invasive surgery, all have cut the time that patients have to spend in hospital. And if you'll excuse me a brief moment of personal nostalgia, I would illustrate that story as follows. The Birmingham Maternity Hospital, where I was born, long since closed. The Children's Hospital, where as a boy I was a patient for a couple of months, long since gone. The Victorian Psychiatric Hospital, that's not actually the time I worked there, I might point out, but the hospital I once ran closed. The General Hospital where I started work, now a community hospital, Guy's and Tommy's, merged but thriving. So in each case, I say, fair enough. Our vital interest as patients and as staff is in care and health, not bricks and mortar. Now, yes, we do need healing facilities and modern equipment, but the where and the how is bound to keep changing. And for good reason. Some beds and buildings will doubtless continue to close over the coming decade, just as they will in France and Germany, in the US and the Netherlands and Sweden, and any other country that you care to name. Some treatments are going to be concentrated further. And acute stroke services are the example du jour, and the stroke patients that I recently met at Charing Cross Hospital, who'd been blue light ambulanced across London, driving past other hospitals on the way, would certainly agree. And that is why, under the fantastic leadership of Bruce Keogh at NHS England, we're working with commissioners and with hospitals across the country to designate 40 to 70 major emergency centres alongside roughly the current number of existing emergency departments. And as we take a hard look at NHS England's 14 billion portfolio of specialised commissioning, then on grounds of quality or efficiency for some tertiary conditions, we are going to choose to work with a smaller number of leading hospitals. And I have to tell you that our selection of those long-term partners will also partly be influenced by the maturity of the relationships that these hospitals exhibit, both in terms of win-win contractual behaviours over the next 12 to 24 months and their shared understanding of the medium-term financial context within which the whole of the NHS is having to operate. We cannot have a situation where overspends in one part of the system are continuing to suck money out of mental health services, primary care services, other parts of the NHS at a time when real budgets are flat. Now, interestingly, although 175 service lines across 280 providers are now defined as specialised commissioning, in fact, it's just 76 providers who account for 80% of our specialised commissioning spend. So I think that suggests that we do need a more realistic, tightly drawn categorisation. But for those services that are genuinely specialised, our commissioning approach is going to be influenced by access and, of course, by quality and volume considerations. But it turns out that only around a third of current spend in specialised commissioning is for planned infrequent services, as against either urgent or frequent services. And it's those planned infrequent services where obviously access considerations are of least importance. And only about 10% of our specialised commissioning spend is for highly specialised or rare conditions. So we are going to be making changes in specialised commissioning that will improve efficiency and quality, but we are certainly not talking about centralising £14 billion of care. In any event, how typical are these sorts of specialised services where greater concentration is now required? Nye Bevan famously said that he would rather be kept alive in the efficient, if cold, altruism of a large hospital than expire in a warm gush of sympathy in a small one. In fact, he died at home in Buckinghamshire. But in any event, that was 50 years ago. And partly as a legacy of tightly controlled NHS spending from the late 1970s until the late 1990s, England already has now quite concentrated acute services with a stronger degree of regionalisation than in many other Western nations. So even our smaller acute hospitals tend to have an average of around 400 inpatient beds. And it turns out that there is not much convincing evidence that the minimum efficient scale is higher than that. Monitor are also doing very interesting empirical work in this area, and they're going to be publishing their findings soon as well. But in any event, I think most of us would agree that beds are an increasingly anachronistic currency for assessing the clinical content of a local acute hospital, a community, or dare I say cottage hospital, an urgent care centre, an elective care centre, an expanded primary care centre, and so on. This traditional taxonomy is actually blindsiding us to new way forward. I know there are pushes and pulls here. There are a push for larger hospitals, often driven by aspirational medical staffing norms, and in some cases by local recruitment difficulties, and competing claims about safety, which is why my colleagues Bruce Keogh and Jane Cummings and Tim Kelsey are rightly pushing so hard, together with the CQC, for transparency of safety and quality data, so these judgments really can be evidence-based. But just as there's been a push for centralisation, there's also been a pull for more local and community-orientated services, which is increasingly feasible, as other countries have been showing, as a result of new technologies like e-consultations, remote monitoring, teleradiology, even EICUs. And let's also remember that treatment approaches are never static. The history of medicine is the history of conditions that began yesterday in the teaching hospital and tomorrow will be in the community clinic, and miniaturization and digitization are actually speeding that diffusion process. So too is the changing needs of our patients, often frail, some with dementia, many with multi-morbidities. Combined with the changing opportunities of new technologies means this, I think. If we creatively, and if we, in a deep-seated way, challenge some of the self-imposed constraints, then we're going to find we do have some new options around how we design care. Well, what do I mean by self-imposed constraints? As was quite widely reported at the end of last week, coming back to the NHS after a decade of working internationally, I've been struck that certain features of how we organise care, which we regard as self-evident, are in fact just contingent choices, whose original rationale is often lost in the mists of time, irrelevant or now unhelpful. And I agree with the Royal College of Surgeons, for example, that inflexible European court reinterpretations of what the European Working Time Directive was meant to achieve are undermining medical training in some specialties and distorting hospital provision in some parts of the country. Now, we do, of course, need high-quality training for the next generation of health professionals, and we should never go back to the days of overworked and overtired junior doctors that was widespread in the 1980s. But does our historical assumption hold for all time that every NHS acute hospital needs a full complement of trainee doctors to keep services afloat? That may have been a pragmatic response during the decades when the number of hospital consultants was so constrained, but we've had a 76% increase in full-time equivalent consultants since 2000. So what if, in some smaller NHS hospitals, we decided on a different medical staffing model, more akin to that of some of the European hospitals? And just to pursue the argument, as the Royal College of Physicians' Future Hospital Initiative has shown, consultant expansion has often meant more subspecialisation, which, while desirable in its own right, has sometimes fragmented care for older patients with multi-morbidity. I'll just give you an example of what this could mean. If you imagine a 79-year-old woman with type 2 diabetes, hypertension, COPD, osteoarthritis, osteoporosis, then if you take single condition-based evidence guidelines, that woman will be getting 19 doses of conflicting and adversely interacting medicines each day, which is why some people have argued that we need actually to, alongside subspecialists, have more general physicians back or hospitalists working alongside advanced nurse practitioners, sessional GPs, network staffing arrangements with other trusts. And in our heart of hearts, I think we all know that despite the theoretical flexibilities offered by Agenda for Change, to date, much of this work has in fact been assigned to the too difficult box. And it's very good to see that NHS employers, Health Education England, a number of the medical royal colleges are all now beginning important work in this area. But let me just be clear, I am definitely not suggesting a wholesale reorganisation of medical training and staffing across England. What I am arguing is that medical training and staffing should not drive the wholesale reorganisation of district general hospitals across England. The tail should not be wagging the dog. If we want to be evidence-informed in our policy making and commissioning, then let's pay heed to research from people like Martin Gaynor and Mauro Ladicello and Carol Proper at Bristol, who've spotted the striking fact that between 1997 and 2006, around half of acute hospitals in England were involved in a merger. And to put it kindly, their peer-reviewed results found little in the way of gains. So, yes, we will need to merge and centralise in a number of cases, but that should not be our overriding meme. Let's instead adopt the slogan, horses for courses. In some places, mergers of traditional reconfigurations will, after careful stress testing, be needed, and they will have my and NHS England's strong support. Just given that to reconfiguration of cardiac and cancer services in north-east London, for example. But I also think we need to let complementary models emerge to be tested and adapted over time in different communities. So in many places, yes, our current models are successful and durable. But let me just give you a few kind of concrete examples of some of the sorts of ideas that have been off the table since 1948 and maybe we should now put on the table. So in many parts of the country, new models of general practice are being discussed. We know about those, extended primary care. But what if, in addition to that, rather than just perpetuate what I think is the increasingly arbitrary boundary between what GPs and community-based services do on the one hand, and hospital outpatients and diagnostics and some inpatient care on the other, what if those health professionals decided they wanted to come together, perhaps even with social services, and form new multi-specialty provider groups? And what if they decided they even wanted to take delegated multi-year budgets to manage defined populations for a population? What if some of those groups decided to team up with a local community or acute hospital? Or what if some of them decided to do the exact opposite? What if they said, actually, we would like to have direct admitting rights to the local hospital, but without managing it, and we'll fund the marginal cost of admissions, but we will pay for the infrastructure, the fixed costs on a unitary payment? Or what if some of these smaller hospitals said, you know what, we can make it, but we're going to need to club together with other smaller hospitals, not necessarily our next-door neighbours? And what if some of these services, as patients gain more influence over how care is commissioned, said, groups of midwives coming together, new provider forms? What if we saw new types of mental health services that help expand IAPT-type services? What if we saw, following Winterbourne View, a terrible situation there, more local, non-institutional services, people with learning disability commissioned from the third sector? All of these ideas, it seems to me, and several others like them, offer quite considerable promise. But none of these ideas should be imposed on the NHS as a national blueprint or reorganisation. Instead, what I want to see, and I am completely confident that this is now a shared view with Monitor and TDA, is an NHS that is more flexible, more adaptable, where national and local thinking converge to create different clinically and financially sustainable paths for particular communities. And in every case, we should embark on them only having very carefully stress-tested the assumptions on which they're built. The new models need to show how they will help solve the particular issues confronting the particular health problems in a given community, with proper safeguards against unintended consequences. Patients need still to be able to make meaningful choices. Providers need to show that they are equitable and can meet high clinical standards and live within a locally sustainable funding envelope. There'll need to be independent evaluation of each of these new models with regular performance benchmarking against comparable areas and periodic opportunities to decide whether to continue or amend these arrangements. But subject to those tests, I think an important part of what we now need to do is get some creativity into these kinds of conversations. And that brings me to my third of three key points, which is that when you're in the heat of the here and now, we all know it's sometimes difficult to stand back and see some of the bigger changes that are unfolding, some of the wider opportunities that we've got. And I say that because I actually believe that we now, not just here, but in all industrialized countries, are on the cusp of at least three quite fundamental shifts in the practice of modern medicine. And the choice for us all is whether we're going to embrace them, or whether the NHS is going to harness them to our cause, or we're just going to wait for them to wash over us or try to muddle through. And that's the choice we've all got to make. So what are those three? Well, the first I would draw your attention to is personalisation. And we're a decade and a half on from the Human Genome Project, but we're still very early in the days of any clinical payoff. As biology becomes an information science, we are going to see a reclassification of a lot of diseases. Things that we thought were one condition will turn out to be multiple, as we're now seeing with cancer. So things we thought were common diseases may, in fact, turn out to be a collection of rare diseases. That's going to require much greater stratification in the individualized diagnosis and treatment, moving, as the phrase goes, from carpet bombing to precision targeting, and from one size fits many to one size fits one. And I think the NHS should be at the forefront of this global medical revolution. And that's one of the reasons why today I'm announcing that NHS England is going to be launching a competitive process for the nation's leading hospitals and clinical research centres to join the UK's groundbreaking 100,000 Genome Project, which is one of the world's highest profile initiatives in this area. We're going to be issuing an ITT at the end of the month, followed by 2 bidders' days and submissions in July, and the announcement in the autumn of Wave 1 trusts who are going to participate in this programme from next year. And in parallel with that, we're going to be consulting on moving to a new model of regional genetics labs to upgrade and industrialise NHS capabilities in this area. And I would say in that context that we are never going to be the country that pays the highest prices or adopts new treatments regardless of how well they work. just so we can say we're innovative. We'll happily leave that accolade to others. But what we should be is rigorously pro-science, pro-research, and pro the rapid spread of useful improvement. And that, I think, is where, if we can get them firing on all cylinders, which I think we can, academic health science centres, networks have such an important role. And that's because I do genuinely believe, and I say this now thinking partly of the comparison with the US, that if we get our act together, we can actually offer something to the world that the US never can in this area. And that is because the NHS potentially is a unique combination of biomedical research, population-orientated primary and specialist care, serving distinct patient groups with longitudinal data to match, as the terminology goes, the phenotypes with the genotypes, aligned financing system, and a rigorous focus on value creation. Those are the ingredients that are going to be needed for this revolution, and actually the NHS could be the place on the planet where we really seize that. Second area where we're going to be seeing major transformational opportunities obviously is in data. You all get that, driving transparency and quality improvement and proactive and anticipatory care. And for example, researchers have now shown that electronic health records, if they were used properly, would have been able to detect 5.5 years early the impact that a diabetes drug was having on heart attacks. And we also know that whereas cancer outcomes have improved very substantially, with half of cancer patients now surviving at least 10 years, according to the Cancer Research UK, compared to only a quarter in the 1970s, we still have this preventable problem, which is that perhaps a quarter of cancer patients are only diagnosed when they turn up in the A&E department, and their prognoses are therefore much worse. Which is why I say, in the context of the debate on care.data, proper data linkage between GP systems and hospitals and other healthcare providers to create secure, confidential, longitudinal information that allows us to target prevention and quality improvement, as well as discover new treatments and cures, is absolutely essential if the NHS is to deliver for the people of England. And the third element of this big revolution in modern medicine that I think we've got to also take account of is the fact that we stand, I think, on the cusp of a revolution in the role that patients and communities will play in their own health and care. It's obviously a huge topic, but I do believe that harnessing what I've called this renewable energy is potentially a make or break opportunity for the NHS. Not the free market economy, but the free economy. And that's why, for example, NHS England has just launched an initiative to work with 150,000 people on so-called patient activation, why we're backing the new NHS Citizens Assembly. A number of patients groups are arguing for personal health budgets, why we should be doing more to support, you should be doing more to support the 1.4 million full-time unpaid carers at work across the country. It's why the £500 million worth, which I suspect is an underestimate, of volunteer support that the NHS gets each year should be nourished and stimulated. And above all, it's why I think we all need to recognise, and I speak to myself as much as to you, that changing the NHS is not merely a techno-rationalist activity, it's health as a social movement, and we need to work with communities and social organisations, civil society, local government, faith groups, patients groups, and many others. So, I think there is a coming revolution in biomedicine, in data for quality and proactive care, the role that patients can play in controlling their own health, and our job is to grab these opportunities with both hands rather than letting them wash over them. So to wrap up, these are the sorts of questions and ideas that we're going to be working with you on, with other NHS bodies, and with our partners over the coming months. By the autumn, and following NHS England's call to action last year, we've committed to giving our point of view, and I've committed to giving my personal point of view, on the NHS prospects for the next 5 years. Not a 5-year plan with a capital P. That can't be done in isolation from knowing what the NHS funding will be over the next Parliament. But instead a 5-year forward view with a capital F and a capital V, which clearly describes the opportunities that we have in front of us, the big ticket questions we need to solve, the sort of new care models that could succeed in the way that I've just been talking, the more permissive local policy and regulatory environments that it's my responsibility and those of my colleagues nationally to create for you, alternative scenarios for demand and for efficiencies and what both imply about funding, the comparative advantages that a National Health Service offers and how we better capitalise on them, and how investment in the NHS supports, not drains, from a prosperous and growing Britain. So nationally, we're going to be working with other key partners on these, and locally, our next steps is, together with Monitor and TDA, to compare and triangulate the 5-year forward views that each CCG and provider is supposed to have drafted by the end of June. We're going to take those to identify particular pressure points and constraints that stand in the way of sustainable solutions in particular geographies, not taking an institutional or a commissioner-provider focus, but a place-based focus. And then in early July, we're going to set out the next steps on what this forward strategy process needs to look like. So, in conclusion, I would say this. I know times are difficult. The last time the NHS faced one of these defining moments was in the early 2000s. And as you all remember, under quite different economic circumstances, we received a big check from the British people for catch-up investments, 160,000 more health professionals, modern infrastructure, better cancer and cardiac care, an end to notoriously long waiting times. Those were all huge achievements which you've managed to sustain through these lean times. As you go back to work at the end of this conference for 14-15, it is absolutely central that we continue to do all we can to do that. But part of the settlement in the early 2000s was also a set of policy mechanisms, payment systems to stimulate activity and hold down inflation, individual hospital governance to incentivize performance at the local institution. But these were just means to an end, and I think that the challenges facing us today are somewhat different, and so we should be open-minded and pragmatic about how we move forward. Resourcing over the Parliament to come will matter, but let's also make sure that we think creatively about our options, disentangling the means from the ends and discarding false dichotomies. And then let's, as leaders and as managers, pay the same attention to effective implementation as we might like to creative system redesign. And let's chart out what it's going to take, and then, frankly, let's get on with it. So let me begin where I end, which is, or end where I begin, in fact, which is that I, as I say, do know that times are tight and the NHS is under great pressure, but I would remind you that the British people's support for our health service is undimmed. The need for the superb care that our staff are striving to offer has never been greater. The issues we face are not insurmountable, but nor will they solve themselves. But if we pull together, then I'm optimistic that we can get this right. So thank you for everything you're doing.
Well, we have about 15 minutes for questions from you. You'll see people going up the stairs with paddles with numbers. If you could just wave those paddles at me. It's not an impromptu game of ping pong. If you just sort of go to one of the people with a paddle, and then I will come to you for some questions. Just to kick things off, though, I can't remember PMQs for a very long time when the NHS didn't become the subject football that was booted from bench to bench. Were you therefore surprised, relieved, appalled that there was not one single mention of the NHS in today's Queen's speech?
No, because I think we are not looking for more legislation to do the things we need to do. I mean, there's obviously a debate about many aspects of how the health service needs to unfold, but for the most part, it's not a shortage of new laws that is standing in our way.
The description that was given by Stuart Rose, that when you have a lofty leadership position, it's the loneliest place in the world. Are you lonely, Simon?
Actually, no, I'm finding a lot of old friends here. It's extraordinary, although I'm on better behaviour than I have been at some of these Confed meetings in years gone by.
Right, okay, well, let's have we got, could you wave to me your paddle? The lights are slightly in my eyes. Number 3, whoever's with number 3, you got a question? No, okay. Who has got a question? Someone wave to me who has got a question. Number 4, yes, over there, thanks.
Simon, thank you. My name's Deborah Harris. I'm a non-executive director at Moorfields Eye Hospital. We have one major site in London, but we have 20 or more sites across London and the South East, plus operations overseas. Yep. I'm interested in your plans for specialised services, Moorfields being eye care, ophthalmology. We also have a BRC, and are very much embedded with the 3 prongs of education, research, and clinical care. We're quite concerned about the constrictions in specialised services that are mentioned, and we just want to get assurances that in your review of it, you will look at different forms of delivery of care, such as the Moorfields model, which is a networked form of delivery, and we work very closely with other hospitals, so we'd just be very interested to hear your comments on that.
Sure, and your concern is that some of the broad proposals around specialist commissioning suggest that single specialty, single disease group clinical sites are less viable than those that are multi-specialty. Is that the point?
No, the opposite. No, the
You
actual
want to
opposite.
be.
We're asking you to look at where it has worked effectively and see about the lessons learned that could possibly be applied elsewhere.
Right. Well, I mean, I think the point I was trying to make is that we do need to have a conversation about many aspects of our specialised services, but that for reasons I've kind of described previously, I think in part to ensure that CCGs got off to a good start in 13-14, there was a very substantial expansion in the range of care that was classified as specialised commissioning. And I think now that CCGs are up and running, it's worth having that conversation to see whether that is standing in the way of proper population-based planning. But as to your question about the interfaces that exist between different specialties in providers, I mean, there clearly are lots of points of connectivity, and where we sometimes go wrong is by having a conversation about major trauma that's separate from a conversation about vascular services, that's separate from a conversation about many other supports we need. But set against that, I do also believe that we have a bit of a tendency to think that everything is connected to everything else in an utterly unalterable way, and therefore if you do something a little bit different here, you get a massive domino effect, and all of a sudden the whole of your services are unviable. So I think we just need to take a much more evidence-based and pragmatic look at some of what's being proposed.
If you put your hands up, we're going to change the whole paddle model here, and I'm going to get the paddles to come to you because nobody's really moving. So if you stick your hands up really, really high. Thank you. Number one. Yeah.
Hi, I'm Shane Gordon, CCG Accountable Officer in Essex. I was really encouraged to hear you setting out a model of local innovation rather than national policy to create essentially a huge laboratory to see what models work and to make them adaptable to the local environment and the local needs of our populations. What I'd be keen to know is what you think we can do as an NHS family to resist the inexorable pull of the postcode lottery argument, which does often arise from our local populations looking over the fence at our neighbours and saying they do it differently. So how do we work to hold off that tension while we do the necessary local experimentation?
Yeah, sure. Well, I mean, the extension of the argument will be that somehow by not doing this, i.e. the current position, we don't have variation in clinical practice or in care delivery, and of course we do, and the NHS Atlas of Variation and any other data set that you care to look at demonstrates that that variation still exists, and managing that variation is an important task for all of us. I guess what I'm saying is we've got to have two thoughts held simultaneously, which people sometimes prefer, it's all of this or all of that, and actually it can sometimes be kind of both and the both and is this, which is that I don't think 1,000 flowers bloom, kind of everybody just go off and try and figure it out in some completely sort of chaotic and poorly designed way is going to produce us what we need. And actually the history of some of this in the NHS, let's be frank, is that people merrily hop from one bright idea to the next without passing through the intervening stage called implementing it and seeing if it works. So that intervening stage is quite important. And so, yes, we need local adaptation, but I think we also need to do so in the context of a set of national thoughts about the kinds of changes that are going to be required, and then we've got to find a way of bringing those together so that we can have that sort of structured conversation in particular health communities. And that's kind of easier said than done, but I think the alternative is we end up either with a great disconnect between what individual providers think the future of their health systems should look like versus what commissioners think, or people just following the latest big idea, which is why I tried to stress in the comments that I just made that this is not a new set of national blueprints that everybody's going away now and saying, hey, this is the answer, it's this, let's get the GPs and the consultants into a single. No, that won't be the answer in many places, but if you think it could be the answer in your neck of the woods, should you be able to look at that? Yes, and as you do look at it, answer the tests, how your mechanism of your theory about how this is actually going to get you there would work, and we will work with you on that.
Any of the other paddles have another question? Just wave to me if you don't. Put your hands up. Thank you. Number 3.
Thank you, Simon. Stephen Dalton, Chief Executive of the Mental Health Network at the NHS Confederation. My question is essentially about pace. I know that you haven't been here for the last year, so it's not your fault. But you are still responsible.
I've been here for the last 9 weeks, so that's my fault.
Yeah. I'll blame you for the last 9 weeks then. You are responsible for some things in specialised commissioning until such time as you perhaps find a different and better way of dealing with that. And your comments are very welcome around specialised commissioning, particularly in mental health. I suppose my question is essentially about pace. People have been waiting a long time. There have been various kind of excuses, if I could call them, made. But in the meantime, I don't want to be too sanctimonious about this, but in the meantime, what providers are seeing is that the wrong people are in the wrong beds all over the country. And I'm just wondering what hope you might be able to offer people that this is going to change sometime soon.
Well, I think the mental health services are actually a very interesting example of a broader point, and I'll come on to the question you raised specifically in a moment. But that is, we do have a tendency to, which I think is consistent with what you're saying, to project the reason we can't do something onto whatever were the last set of administrative changes that occurred in the National Health Service. So if I had a pound for everybody who told me, the reason we've not got all of the services in this city sorted out is because last April there was a change in the way CCGs worked and the SHAs or something, and I sort of left scratching my head thinking, so in other words, last March it was all going fine, and then it just kind of reverted to this kind of position. So the reason I mention that in the context of mental health is, of course, one of the things that's going on inside mental health services is people are saying, we don't like having effectively block budgets or capitated population budgets because it means that we've not been getting extra resources as we've been doing more stuff in the way that the acute sector has. And that conversation is bubbling up in mental health at just the same time as the acute sector saying, you know what, this kind of treadmill of payment by activity, we need to get off that. We need to find a way of having a more broad-based conversation. And the truth is there's legitimacy to both points, but I think sometimes the grass is always greener on the other side. So in the context of mental health specifically, I think we know that there are actually a lot of things that have been done in mental health that really do signpost the way for a lot of the care redesign that I was talking about earlier. But there are also some pretty big frustrations. And I was with the crisis teams in central Birmingham with the Birmingham Mental Health Trust a couple of weeks ago. And I mean, a lot of that is incredibly good, but just the ability to do crisis services, to make the connections with the primary care teams, to get the connections right with the police and with social services, which they're doing a really good job on. I mean, it takes an awful lot of work to be able to do that, and which is why I think so often in mental health people are succeeding despite the system, not because of it. So I don't have an easy answer to your question, but I do think mental health services are something that we're going to really need to get behind because there is a genuine sense that they've been a bit off the radar in recent times.
Lady at the front.
Hello, my name's Kath Parton. I'm Chief Executive of an organisation called the Older People's Advocacy Alliance. Therefore, I'm here as a third sector representative. For the last 18 months, we've been running a pilot in five areas of the country in partnership with Macmillan, recruiting and training older peer volunteer advocates who themselves have been affected by cancer to support their peers. Mm-hmm. This project has been highly successful to such a degree that the big lottery have given us £1 million and we've had another £500,000 off Macmillan. My question to you is, this project has been successful not with the help of the health service, sadly. We've encountered many barriers to referrals. How can you help us being my organisation and the 25 other organisations in this partnership and Macmillan, to educate our health colleagues in the very valuable work these volunteer peer advocates can do for older people affected by cancer?
Yes. Well, first of all, thank you for what you're doing, because I'm completely personally convinced that the kind of model that you described is what we're going to have a lot more of in the future. And talking to people, as I was doing this morning in the health service here in Liverpool, and some of the programs that they were pretty clear that this is the kind of thing that actually, in a way, people don't know or don't notice until it's not there, and then they wonder what just happened. So that's a more general problem that I think we have, not just with the work that organisations like you do, but with the role that carers play, with the role that social services play, the role that effective primary care can play, in a sense, which is, if you think of the health system as a sort of engineering system, somebody who said, you're the heat sink. And when you take the heat sink out, then all of a sudden it goes into meltdown. So part of what we've got to do is make it, recognizing that there are, people are under huge financial pressure in the health service, under huge financial pressure in social services, help enable people to make smart decisions at the margin about understanding what kind of investment they get, what sort of return from supporting the work of organizations like yours. But, I think of a visit I did with some drug and alcohol workers in London, run by Turning Point, which previously had been run by the local social services authority and by the Mental Health Trust. And actually now it's a combination of Turning Point and those two statutory organisations. And without a doubt, they were not only being more effective, but getting far more bangs for the buck, because a lot of the people who had gone through the programme as clients were now client mentors, and it was a kind of continuum of being a user through to being a provider. These are hard things to get a feel for when you're trying to manage a system as against managing an institution, and we've got to change that.
Are there any questions on that side? Over there? Yes, if there is one, anyone there? If you just pass it along as quickly as you can, that would be marvellous, thank you. Great.
Thank you. Amit Bhargav, I'm a Clinical Chief Officer for Crawley CCG. In the past, we used to have, if you said no or...
Hey, could you perhaps just stand up and speak up a little bit? We're having difficulty hearing you. Thank you.
In the past, if you said no or didn't do anything or kept things quiet, you're successful in the NHS. And you are proposing that we need to transform services and do innovative stuff. With that will come failure. Some things will not succeed. And as a break-even CCG, if you're going to transform things, some things will not succeed. And what is your feeling about supporting people who tried their best and were unsuccessful through the assurance process, and how the area teams will support this?
Yeah, well, my vote is for success, obviously, but I recognise that in order to get that, we're going to have to do some well-controlled experimentation on the way. And in general, I think that we don't apply the same disciplines to the way we go about innovating in our service delivery that we would expect clinical professionals to apply in their own workplace. And what I mean by that is we do too many, too many pilots that are not rigorously conceptualized and effectively managed, with frankly different approaches that we run alongside each other and evaluate. And so we've got these integration pioneers that are up and going now, which I think are potentially very good. But what I really would like to see is a more quasi-experimental model than that, where we say, okay, this is the intervention, this is a hypothesis about what it's going to do, this is the control, this is what the operational research or the comparisons are going to be, and actually just get much more quantitative about how we do new things in the NHS. And I think that if we do that, we'll actually get a lot more support from our clinical partners than if we just kind of try and do the latest and greatest. So part of it is about saying, what are the big questions we're trying to answer? How are we going to set these tests up in a way that we actually will know whether they succeeded and could then generalize from them? And how do we get some of the implementation rigor rather than just the press release?
We have time for one more question. I think there's one over here on this side of the hall. Yeah.
Hello, my name is Daksha Patel. I'm an independent lay member for Leicester City CCG. I've also been a previous chair of Leicester City Primary Care Trust. And for the last 5 years, we've been conducting quality visits to GP practices, which I've been participating in. You've not said very much about primary care. We've got the tension between the left shift and the funding for doing that within primary care. We've also got the tension in terms of recruiting staff within primary care. And I see a lot of stress within primary care to try and deliver all of that. Have you got any views or a sense of what NHS England is doing? Alongside that, we also have the LAT, the local area teams, actually coming down on expenditure, as a previous person said, in looking at tests for trying out new ways of actually making that left shift. So just your views on primary care, basically, and where we're going in the next 5 years.
Thank you.
Well, it goes without saying that primary care, if you look at from the outside into the NHS, you would say that universal primary care is one of its design strengths, but then the next thing you would say is it's a bit of a puzzle, the way it's currently in some ways resourced, and sometimes the rather rigid handoffs that exist between primary care and other parts of the health system. So my answer to your question is, in an era where there is no real growth in NHS spending, robbing Peter to pay Paul obviously gets you so far, but part of the reason I talked about trying to redesign the ways that GPs are working with community nurses, with social services, with consultants, with the rest of the service, is that I think only by really tearing up the distinctions that we've had since 1948, which is, some of you may have been, I mean, a guy called Roy Porter, who sort of one of the famous historians of the NHS, said the way the NHS was set up was that the founding deal was that the consultants got the hospitals and the GPs got the patients. Well, I just don't think that's a good principle for organising services going forward, and part of, therefore, what we're going to have to do with GP services is change that deal.
That is unfortunately all that we have time for. Simon is going to be around, I think, for a little while longer, so if you bump into him outside, I'm sure he'll be happy to answer your questions. I can tell you refreshments are now being served in the exhibition areas. Do show your support by visiting the stands. And please, before we go any further, before any of you move, a very warm thank you to Simon Stevens. Thank you very much.